Breaking your shin bone, the tibia, is one of the most common and most serious fractures an adult can get. For decades, the way we fix it has been pretty much the same. Surgeons insert a metal rod right down the middle of the bone. It's been the gold standard for sure, but it's a standard with some well-known problems. So what if there's a better way? Today, we're going to look at a shift in surgical technique that might just change everything.
And this, right here, is the central question for every orthopedic surgeon. You see, the goal isn't just to get the bone to heal straight. That's a given. The real trick is to do that while protecting the function of the knee joint, which sits right on top of the fracture. It's an incredibly delicate balancing act, and for years, the traditional procedure has had a fundamental conflict built right into it. Okay, so let's dig into the classic method. It's called infrapatellar intramedullary nailing. I know, it's a mouthful, but for a long, long time, it's been the undisputed champ for fixing those fractures right in the middle of the shin. To pull this off, the surgeon has to make an incision either through or right next to the patellar tendon. That's the big tendon connecting your kneecap to your shin. But, the incision isn't even the hard part. The real challenge is the position you have to put the leg in just to get that nail inserted correctly. And this is the paradox at the heart of the whole thing. To get the nail in, surgeons have to bend the knee way, way back into what we call hyperflexion. But look at what happens when you do that. The powerful quadriceps muscle at the front of your thigh gets stretched to its max, and it ends up pulling on the top piece of that broken bone, yanking it forward and out of alignment. So the very position you need for the surgery is creating the exact deformity you're trying to fix. As you can imagine, this just leads to a whole cascade of problems. First, you can get what's called a procurvatum deformity, which is basically a fancy way of saying the bone heals with a forward bow in it. That bent knee position also makes it a real nightmare to get clear x-rays during the operation. But honestly, the biggest issue for patients? Chronic knee pain. I mean, look at these numbers. Studies show it affects anywhere from 10 to a staggering 80% of them after this procedure. That's a huge deal. So the big breakthrough wasn't some new kind of fancy nail or a new implant. It was much simpler and much more elegant. It was a fundamental shift in how the patient is positioned on the operating table, an idea that attacks the root of the problem. Instead of bending the knee all the way back, surgeons started keeping the leg nearly straight in what's called a semi-extended position. We're talking just 15 to 20 degrees of bend, and with that one simple change, you completely neutralize that deforming pull from the quad muscle. Just like that, the main force that was causing the misalignment is gone before the surgeon even picks up a scalpel. And this simple change unlocks a whole new approach. So, with the leg straight, you can now use a totally different entry point. Instead of going below the kneecap, the incision is made above it. That's the suprapatellar part. The quadriceps tendon is carefully split, and then a protective sleeve or cannula is inserted. Now, this part is absolutely critical. The sleeve slides in behind the kneecap and acts like a shield, protecting that delicate cartilage from getting damaged while the nail is put in. With the joint protected and the leg stable, that nail can be guided into the perfect position. Okay, so the theory sounds great, right? It makes perfect sense. But in medicine, you need to see the data. Theory is one thing. Proof is another. So let's look at the evidence and see how this new suprapatellar approach stacks up against the old school infrapatellar method in some head-to-head studies. Well, the first advantage is just pure efficiency. One study clocked the setup time for the new semi-extended position at just over 10 minutes. The old, complex, hyperflexed position, almost 19 minutes. In the world of surgery, every minute counts, and saving nearly 9 minutes of setup time is a huge, huge win. And this right here is a massive safety win. Because the leg is in a more natural, straight position, getting clear X-ray images is so much easier. And what's the result? A dramatic drop in the amount of radiation everyone in the room is exposed to, by about 50%. That's a major benefit for both the patient and the entire surgical team. But here's the million-dollar question. Does it actually fix the bone better? Well, the data is pretty compelling. At the 6-month follow-up, this new suprapatellar approach achieved a near-perfect 99% alignment success rate. Now compare that to just 91% for the traditional method. It simply does the number one job of the surgery, getting the bone straight more reliably. And of course, that better surgical result translates directly into a better experience for the patient. When you look at validated functional scores 6 months out, patients who had this suprapatellar surgery reported significantly better knee function and less pain. They are getting back on their feet and back to their lives faster.
So, let's recap. We have a technique that's faster in the operating room, it uses less radiation, it achieves better bone alignment, and it leads to better outcomes for the patient. It really forces us to ask the big question, is this the future or is it just another passing trend?
When you lay out the evidence, the argument is pretty powerful. The suprapatellar technique gets more accurate alignment, especially for those tricky fractures up near the knee. It's more efficient, it's safer from a radiation standpoint, and it results in less pain and better function. It systematically solves all the known problems of that traditional hyperflexion approach. The case for this being the new standard of care is incredibly strong. And hey, don't just take my word for it. The medical community is really starting to get behind this. This powerful statement from a 2023 review in the Journal of Clinical Medicine really says it all. The experts looking at all the data believe this technique is poised to become the new benchmark for treating pretty much all of these tibia fractures.
So we'll end on this thought. The evidence makes a powerful case that this new approach is just plain better for most patients. So the question really isn't if it's better anymore. The question is shifting to when, if ever, should surgeons still use the old approach? It really marks a remarkable step forward in how we fix a very common and very serious injury.